We're at episode 2.
Jason,
Fantastic.
here we are again.
Yeah, we heard some fantastic feedback from episode 1. I was really surprised that the birth of that first episode and how well it was received, not only by doctors, but a lot of patient advocates, families of patient undergoing breast cancer treatment right now. So it was great that a big audience listened to our first episode.
I agree. I'm impressed by, how many people have been interested in it. And so I'm super interested in the second episode about your opinions about not what has been presented in the past year, but
Yeah.
actually what will be presented, what will shape practice. And, we are here to answer tough questions. And what
Mhm.
questions are tougher than the questions on the data that hasn't been presented yet, right?
Yeah, definitely. What's is anticipated to be presented in 2026 and beyond. So it's a very exciting times we live in the breast oncology world. We're getting newer therapies, cutting edge therapies. Definitely exciting for our patients. So we're gonna lay down the landscape that's coming.
I have to say, I do miss you here by my side. Doing virtual is not the same, but I'm excited about this second
Me
episode
too.
of the Breast
Yes.
Friends podcast. Here we are. And so, is there anything that you would like to start from? What do you think is coming our way in 2026?
Yeah, so a lot of stuff are coming our way, but it's fair always to start with the most common subtype of breast cancer, which is the hormone positive, HER2 negative breast cancer. And when we talk about the neoadjuvant setting, the neoadjuvant setting for ER positive breast cancer is really an area of unmet need. Historically, we haven't had agents that can achieve past CR adequately and consistently, like we've seen in the HER2 positive and triple negative. One study that is trying to tackle that is the Keynote 756. And the Keynote 756 is not a new study for a lot of us because they presented the first result of that study earlier on when one of the primary endpoint has completed, which is the achievement of past CR. But just as a reminder of the Keynote 756, this study took early stage hormone positive, HER2 negative breast cancer. Patient to enroll needed to have a T1C, T2 not positive, or if they had bigger tumor like a T3 lesion above 5 centimeter or a T4 lesion involvement of the breast that you can see on the skin, they can be node negative. Now, something about that study that I remember when we're enrolling on it was a little bit frustrating is that you need to have a centrally confirmed grade 3 disease. And that led to a lot of patients that we felt are eligible. When they go to get centrally reviewed, they were downgraded to a grade 2. So that was one of the hiccups that delayed the accrual on that study. But anyways, the patient were enrolled to either receive the standard of care, which is to just receive chemotherapy with a treatment that we've been using for the past 20 years, which is ACT, so adriamycin cytoxan followed by Taxol, or like switch the role, like start with Taxol and then go to the adriamycin cytoxan, or the intervention arm, which is the same treatment but added to it is the immunotherapy pembrolizumab. And then the patient take the course of treatment and then go for surgery. And the first assessment was looking at the patient who eliminated their cancer at the time of surgery, what we call past CR. Now, that study met its first primary endpoint by improving the past CR. And historically with ER positive disease, the past CR we see is about 15 to 16%, and that's what they saw on the control arm. It was about 15.6%. But then if you look at the arm with the addition of immunotherapy, it did improve the outcomes to about 25%. And that was a delta or absolute benefit of 8.5%. And that was statistically significant. Now, this benefit has been seen consistent irrespective of the stage of the cancer, irrespective of lymph node positivity or negativity, and irrespective, very importantly, of PD-L1 status. So patient, even with negative PD-L1, did have improvement of outcome when given the immunotherapy. However, not as robust of a response compared to the patient that are PD-L1 positive, but nevertheless, we've seen that response. Something interesting we saw also on that study is that the benefit was more profound in the patient who are low ER positive. So the patient that had ER positive less than 10%, these are the patient where we really seen the immunotherapy helped a lot. And the past CR was very close to 60%. 60%, almost double of the past CR rate compared to the patient that just received chemotherapy. Having said this, we also saw the benefit in the patient that have ER positive more than 10%, but it was less of a profound response here. It was about 30% past CR rate. Now, very importantly, that although we saw this past CR improvement, it didn't yet make its way into our standard of care because we were waiting for the second endpoint. And that's the one we're waiting for, hopefully, this year. And that's to look at the event-free survival. So the whole idea of achieving past CR is to eventually translate it into improvement of outcomes. That's what we want for our patient. We want to improve their outcome long term. So event-free survival is a very important endpoint. And I really hope it's going to translate into improvement of outcomes when looking at those patients longitudinally. What do you think, Paolo?
Yeah, I do agree that this is such an important trial for several reasons. First of all, because this population is such an unmet need. These patients, we're talking of the most common subtype of breast cancer, the most aggressive form of this common subtype, grade 3, node positive, large tumors. And we know that immunotherapy did help triple negative disease in this setting, neoadjuvant setting. Additionally, we know that most of the trials, if not all of the trials that showed an improvement in PCR rate with neoadjuvant pembrolizumab have translated in improved EFS. So I'm very confident that we will see a long-term benefit, but as you mentioned, we cannot really change practice just based on PCR because we know that it's a surrogate endpoint. It's an imperfect surrogate endpoint. It's a great news for a single patient, but it cannot really predict well what's going to be the magnitude of benefit. And we know that immunotherapy does come with side effects, sometimes unpredictable side effects. So before adding this to a chemotherapy backbone that already had toxicities, anthracyclines, taxanes, we really want to make sure that this is beneficial. And I do expect and hope that this will be presented in 2026. And if it does, it's going to bring, of course, hope. It may bring a new start of care for this population, and it will bring some headaches because we are in the past few years, we had several new drugs that were implemented in the adjuvant treatment for this disease. And the key one I'm thinking about is CDK4/6 inhibitors, ribociclib, abemaciclib. We know that these agents really reduce the risk of recurrence by a third in this population. But we know that when they were combined with immunotherapy, there were some troubles in terms of pneumonitis, of liver toxicity. And so it's going to be hard because this trial used neoadjuvant and adjuvant pembrolizumab. And so we're going to probably need to piece together all of these studies. And so asking the first tough question of this episode 2, if this trial is positive and we end up using neoadjuvant pembro, would you then also consider adjuvant CDKs?
So that's a very important question. And yeah, you're right. There was a study by Hope Rugo published in NPJ Press with Sarah Tolani that looked at that. They looked at the combination of pembrolizumab with abemaciclib. And that study found something very concerning, is that there was an increased risk of interstitial lung disease, what we call ILD. But there was also increase in grade 3 and possibly fatal transaminitis, elevated liver enzymes. And that study reported 2 deaths because of those side effects that were reported to that combination of drugs. And you're right, one of our mainstay therapies. So those patients that qualify for that study, if they have residual disease or if they're high risk by nature, those patients eventually they would qualify for those CDK4/6 inhibitor. Combining immunotherapy with a CDK4/6 inhibitor is concerning at this point in time. So you are definitely right, because by study design, all patients that enrolled on their study continued the immunotherapy if they were enrolled on the arm with immunotherapy, but it was only combined with endocrine therapy and not with the CDK4/6 inhibitor. So that's going to be a huge gap in the field. And with the data that we already have, although we have data from one study, but it's highly concerning. This is the curative setting. We don't want to kill patients in the curative setting. That's not the goal. The goal is to cure our patients and to give them, to make them prosperous and have excellent long-term outcomes. So for me, I would not, at this point in time, combine an immunotherapy with a CDK4/6 inhibitor. It will be a discussion to be made with the patient in the adjuvant setting. And depending on the risk of recurrence, then we're going to have to tailor it. Either go with the immunotherapy plus endocrine therapy. But if you're going to use a CDK4/6 inhibitor, I would not, at this point, combine it with a CDK4/6 inhibitor. What do you think, Paolo?
No, I agree, and I think here real world data will be key. And so, we're trying to address this to find patients enrolled on trial that receive immunotherapy and afterwards went into adjuvant CDKs. And so, I'm sure we're gonna hear more. But one class of agents that has been showing improvement in outcomes lately that probably is gonna be easier to combine with immunotherapy is actually adjuvant SERDs. We've seen the first data from lidERA, which we discussed about in the first episode, and it was just so impressive to see the first improvement with endocrine therapy after 20 years. But there's so much more besides lidERA.
Mm-hmm.
We do expect to see updates to
Mm-hmm.
understand if the 3-year outcomes are going to also be maintained at 4 years, at 5 years, and it's going to be key. But there's other trials that also are investigating adjuvant SERDs to improve outcomes for patients with ER-positive breast cancer. And I think they are broadly divided in two categories. This
Mm-hmm.
adjuvant third trial, the trials that test a delayed administration of SERDs after the patients have received 2 to 5 years of endocrine therapy. And the two main ones that come to my mind are Cambria-1, that
Mm-hmm.
tests camizestrant in the adjuvant
Mm-hmm.
setting. Now, we
Mm-hmm.
know that camizestrant has shown improved outcomes in the Serena-6 study in the metastatic setting. And so there really is hope that given in this delayed adjuvant fashion after completing 2 to 5 years of standard endocrine therapy, could improve outcomes and reduce the risk of recurrence. And so
Mm-hmm.
Cambria-1 is testing adjuvant camizestrant. And then we have EMBER-4. EMBER-4 is
Mm-hmm.
testing imlunestrant, which also has positive data in the metastatic setting from EMBER-3, which led
Mm-hmm.
to an approval. Imlunestrant is approved in metastatic setting and is going to be tested among patients that received already 2 to 5 years of adjuvant standard endocrine therapy, and then they're going to be randomized to adjuvant imlunestrant for 5 years or physician choice of endocrine therapy. And of course, here we're talking of patients with high risk disease, but these are very broad populations, just like lidERA.
Mm-hmm.
So I do think that if these trials are positive, there's going to be so much hope for our patients. But since I mentioned lidERA, there's also other trials that are testing endocrine therapy up front. There's also the ELEGANT trial that is testing
Yep.
delayed administration of elacestrant, another
Mm-hmm.
the first approved oral SERD. And then there's the one like lidERA testing an early administration. What do you think about this difference between starting with the SERD immediately or later on?
I think it's good to have those options because a lot of our patients are already receiving their endocrine therapies, and those patients, a lot of them now are receiving in combination with CDK4/6 inhibitor. It's good to have the option to go to an oral SERD after they finish their 2 to 3 years of CDK4/6 inhibitor plus endocrine therapies. And for our patient who's starting up front, like you said, we have the lidERA, but the lidERA, the problem with it is when it was designed, it was done as single agent. So you cannot use it at this point in time in combination with CDK4/6 inhibitor or when the approval comes. So a lot of people are thinking, should I give, and we discussed in our first episode, are we going to go with the CDK4/6 inhibitor plus AI or give them an oral SERD? And I think we both agrees, we had this unanimous consensus that we still are going to prefer at this point in time to do the combination with CDK4/6 inhibitor plus AI because of the survival advantage that we've seen with the monarchy study. And if even when you look at the Natalie study, if you just look at the death reported on each arm, you can see there's a huge discrepancy between the patient that were enrolled on the ribociclib plus AI compared to just the AI arm. So I do believe with time, we might also get a survival advantage from the Natalie. So because of that trend towards survival advantage, we're still going to prefer that. But we might not have to do that distinction, especially because of the Cambria-2 study, the sister of the Cambria-1, which was designed for the same upfront patient. But on that study, instead of just looking at an oral SERD compared to a standard of care endocrine therapy, AI or tamoxifen, they are allowing patients to either go on a single agent or to add to it a CDK4/6 inhibitor. So that's very exciting that we're going to see those combo from early on. And we know that camizestrant was already combined with those CDK4/6 inhibitors based on the Serena-6, and it seems to be safe with dealer choice with all three CDK4/6 inhibitor. What do you think about that design of the Cambria-2, Paolo?
Yeah, I do think this is very patient-centric. It's modern. We do want to be able to administer camizestrant oral SERDs with CDK4/6 inhibitors, and we do expect some data from a sub-study of lidERA with abemaciclib. But overall, I do think that all of this really has concrete hope to improving outcomes for patients, and we're gonna figure out if a delayed administration is better or an early administration. We have to consider that these are highly expensive drugs, and so giving these
Yeah.
drugs for many years for all patients is going to be very expensive for the society. And so we need biomarkers, we need more data, we need a lot of trials, and they're coming. And I do think that 2026 will be a big year for oral SERDs and hopefully for immunotherapy.
And I just want to add one more thing here, because you mentioned we are going to get some data with the giredestrant plus CDK4/6 inhibitor. The only worry is I would have a less worry about combining, let's say, giredestrant plus abemaciclib. The one thing we need to clarify is when it comes to ribociclib. Because remember, ribociclib, we need to get an EKG before starting that treatment and then another EKG while on treatment because we are monitoring the QT prolongation. Now, giredestrant have shown one of its side effects to be bradycardia. Now, that's a different thing than a QT prolongation, but we don't know if there's going to be a synergy between the two. So that's a very important thing that we need to clarify when two drugs can potentially affect the rhythm of the heart to see if there is any synergy between them before we extrapolate and start applying in the adjuvant setting. Don't you agree, Paolo?
100%. Same for camizestrant. Also, bradycardia has been observed for several SERDs. And so, once again, it is important to see this data, and hopefully, we're gonna get answers to these many hard, tough questions. But of course, we do want to prevent recurrence, but we also want to have better treatments for patients that do experience recurrence or de novo
For sure.
metastatic disease. And we've really seen the power of SERDs in the pretreated setting, in the second line setting and beyond. We have elacestrant approved, we have imlunestrant approved, and we're expecting probably camizestrant approved soon. But there's also some trials trying to take SERDs to the first line. And I think this is going to be a much tougher setting because we saw that fulvestrant did not improve outcomes in the first line setting, even when combined with palbociclib, which is why we still use aromatase inhibitors. But could instead oral SERDs make it to the first line setting? Is there any trial in the first line metastatic setting that you think may impact practice?
Yeah, so there's two studies in mind that might change the landscape of the first line at this point in time. The first one is the SERENA-4. The SERENA-4 is highly anticipated study. We've been waiting for those results for a while. The SERENA-4 is looking at the same oral SERD that we looked at in the SERENA-6, and that's camizestrant. And here the idea is, does starting with an oral SERD instead of an aromatase inhibitor in combination with a CDK4/6 inhibitor improve outcome? The idea here, you are starting the oral SERD before even the development of an ESR1 mutation. And that's a very important question because we know now that if there is an ESR1 mutation, the mutation that confer resistance to aromatase inhibitors, that oral SERD shine. We know that. We have many studies that prove that, and we have approvals because of that. The idea is, before having an ESR1 mutation, before the emergence of that mutation, does starting an oral SERD compared to an AI will improve outcomes? Because ideally, if you think about it, if you're starting it and an ESR1 mutation will develop, you're still going to be sensitive. You're not going to be resistant. So the idea is, can you do like this 2-in-1 deal and start the oral SERD from the beginning and skip a whole step? So we will see if that will be positive. So the SERENA-4, this study, that's the one that we're really anticipating to be resulted very soon. That's looking at camizestrant plus CDK4/6 inhibitor versus anastrozole plus CDK4/6 inhibitor. And we have the Persevera, the sister study, I call it, to that study. That's with the drug that we just talked about with the lidERA, is giredestrant. And in that study here, they're combining giredestrant with palbociclib and comparing to letrozole with palbociclib. So again, they're trying to go against the standard of care for first-line therapy and seeing if you start the oral SERD from the beginning, can you really improve outcomes? We will see, because you're right, fulvestrant, which is a SERD, but not an oral SERD, as an injectable SERD, did not show that. Did not show that if you do fulvestrant plus CDK4/6 inhibitor is superior to AI plus CDK4/6 inhibitors. But we will see if an oral SERD can do it. Now, definitely, they are exciting. They are highly awaiting study. And one of the very important things about those studies is they can overnight make the use of single agent oral SERD a little bit of an obsolete. Because if you do show that there is improvement of outcome by using an oral SERD, irrespective of a mutation like ESR1 mutation, then the whole idea now that we are pushing and keep pushing our doctor to do check for ESR1 mutation to give an oral SERD can become a little bit of an obsolete thing. What do you think, Paolo?
Yeah, I think we're starting to see this over and over again. A biomarker that in time starts to become almost less useful.
Yeah.
We saw it, for instance, with HER2, with T-DXd. T-DXd initially very active for HER2 positive disease, and then active also for HER2 low. Suddenly, everybody looking at HER2 low, distinguishing from zero. And then we realize it's also active in ultra low, and sometimes it's zero. And so we start lowering the bar, and here, oral SERDs active in ESR1 mutant, but what if they show activity beyond the ESR1 mutant, like we saw with giredestrant in the adjuvant setting? And so here's the tough question for you. If these trials are positive, SERDs move to the first line, oral SERD, CDK4/6 inhibitor, would you use another oral SERD in the second line or just move to something different?
That is a tough question, but I can tell you, I can here extrapolate from our fulvestrant drug, right? So fulvestrant, a lot of time we are stuck with it because that's the only endocrine therapy we have in the advanced setting, and sometimes we recycle it, especially if the targeted therapy, the companion drug, is different. We are willing to recycle it. So here, again, we don't have data. I'm just extrapolating. If I still believe that the patient is endocrine sensitive and there is a targetable mutation, like let's say a PIK3CA mutation or an AKT mutation or a PTEN loss, okay, and I want to give one of those agents as second line, I would rather combine them with another oral SERD than give them with fulvestrant after giving oral SERD in the first line setting. Because we know that those targeted therapy that target the PI3 kinase, AKT, mTOR pathway, they don't work by themselves. We cannot give, for example, capivasertib, alpelisib, inavolisib, those drugs, we cannot give them as single agents. They will not work. We need to add to them hormonal blockade. We need to have something that block the estrogen pathway. So for that reason, I am willing to do another oral SERD if it's being combined with a targeted therapy.
Totally agree. And on that note, let's review again our crystal ball and move on to another disease subtype of which we discussed a lot during the first episode because of, I guess, the excitement of the first data of T-DXd we've seen in the early stage setting, Destiny Breast 05, Destiny 11, HER2 positive breast cancer. We're getting so much better at curing HER2 positive breast cancer in the early stage setting. And I do think 2026 has a lot to give for HER2 positive breast cancer.
For sure.
And the first thing, I mentioned already, we know that Destiny Breast 11 showed that we can replace neoadjuvant anthracyclines with T-DXd and not only make treatment more effective, which is awesome, but also better tolerated, reduce the risk of cardiotoxicity, of neutropenia, of other toxicities. But there is other data that I think will help and may help in this field, which is coming from another large study conducted by a cooperative group in the US, CompaSSER PCR. What do you think of this strategy that is less intensive of DB11, but which has shown interesting PCR data?
So first, I want to say that again for the DB11, me and you, we were both agreed on that one. That the DB11 offer a very, very attractive strategy of using T-DXd for 4 cycles. That was extremely, extremely well tolerated. We don't see an increase in ILD signal like we see when we do it adjuvantly or in the metastatic setting, and that's because you're giving limited doses of T-DXd, and then you give the THP and then send patient to surgery. I mean, I just want people to put this in perspective. You are seeing about 70% PCR rate. 70%. 2/3 of our patients will be able to achieve complete pathological response by the use of that regimen. And only 1/3 of our patients are going to need help. And hopefully those third also will not have those nasty diseases that did not respond, but will have good responses with maybe a little bit of residual disease that won't need for us to throw the kitchen sink at them in the adjuvant setting. That's very exciting. And one thing very exciting about the DB11 that I was thinking about since our last episode are how well the hormone positive patients, so the triple positive, did in terms of PCR. Historically, those patients don't do good on neoadjuvant studies. These are the ones that pull back the past CR, because past CR on the pure HER2 positive, we always used to achieve the 70%. On the DB11, it was close to 80%. But then when you look at the hormone positive, they always pull them back. And historically, it used to be around 40%. So less than 50%, less than half used to achieve past CR. On that study, it was close to 60% in those triple positive. Super exciting. That's why I agree even more. And I like my response with you on the first podcast that I would like to do the DB11 almost universally if I can. Now, of course, there are other studies like you mentioned, like the Compass HER2 PCR. And it's important to note that this study, when it was designed, it was before the DB11. Now, whether this study will still have a role or not, it remains to be seen. But I still believe maybe in the smaller tumor and the patient who don't qualify to the DB11, this is a very attractive approach, because here you are giving an anthracycline-free regimen. You are giving THP for 4 cycles. So THP for 4 cycles. This is 12 weeks. So this is about what, 3 months treatment before you go to surgery. And then at the time of surgery, then you can see what you get on the back end and stratify your treatment then. So it is attractive, especially for those patients that you feel like you don't want to give them a big course of neoadjuvant treatment because they might have smaller cancers. What do you think, Paolo, especially in this DB11 age? What do you think this study fits?
Yeah, I would say fortunately the populations do not overlap perfectly. And so Compasser PCR does enroll patients that have lower risk disease, such as T2 and 0. Not only, but that's a population for which THP is very appealing. And then, we have larger patients with stage 3B, for instance, HER2 positive breast cancer, which were enrolled included in DB11 and not in Compasser PCR. And then, as you mentioned, the ER status, I think, is very important. Patients with ER positive disease are just hard to shrink. They were basically 3/4 of the DB11 population, and this regimen just works so well. Whereas
Yeah.
for patients with ER negative, HER2 positive, 3+, highly sensitive disease, I love the idea of trying THP and then doing an MRI and seeing how they're doing. But in truth, before applying this more broadly, I do want to see the primary endpoint from Compasser PCR, that was recurrence-free survival. We need to see that the strategy of THP times 4 for 3 months not only leads to a nice PCR rate, which in this case was about 45%, but also to promising RFS, that the patients just do not recur with just THP without T-DXd. And so I do think that with seeing this data maturing, we'll figure this out. And I see you have something to say. Go on, shoot.
Yeah, Pablo, because I promised. So I got some I got some feedback from some oncologists that I promised I'm gonna ask you this question.
Go on.
A lot of people like the HER2-DX. They love it. They love it. I know it was developed by our European colleagues, and I know you have insight about HER2-DX. Can you please introduce it to our audience, both physicians and patient advocates? What does it mean, and how was it used on that study?
Yeah, we'll say, we all are used to Oncotype DX and how it completely changed the way we treat ER positive breast cancer. HER2-DX is basically the Oncotype DX of HER2 positive disease. It includes HER2 expression, proliferation, immune signature. It includes all the luminal differentiation, all the features important to predict, first of all, if the tumor is going to respond to neoadjuvant therapy, and then if it's going to recur. And so they did include it prospectively in Compasser PCR and confirm that patients with HER2-DX high or medium have a very high PCR rate, up to 70%, and patients with HER2-DX low instead have a very low PCR rate. And those patients may be the ones that definitely need escalation. Now, it's complex to comment on this data, and HER2-DX was not included in a randomized fashion, but I do think it's incredibly promising. We even validated it in APT and ATTEMPT, 2 studies for stage 1 HER2 positive disease, and it was predictive. And so I think HER2-DX is coming. There is more data coming, a validation study called Definitive that is ongoing. And I do think that our patients would love to know more upfront about their tumor before deciding if to embark on a certain regimen. And so I think Together, many things will collide in 2026. The data from CompassR PCR, the updated event-free survival from DB11, this regimen, DB11, hopefully becoming approved and being used in clinical practice, and biomarker data. And all of this together will help us and probably also help us throw outside of the window anthracyclines and carboplatin, which are tough, and we're not sure they're helping our patients. And so, yeah, neoadjuvant therapy, HER2-positive disease, so much is going to change. But then, as you mentioned, there are still patients that do not have a PCR, and it's always such hard news to give the patient. You endured neoadjuvant therapy,
Yeah.
you tolerated the side effects of this therapy, and still the tumor remained there. There is still residual disease. And we did have some news in 2025. We discussed it. Destiny Breast 05, T-DXd, hopefully will be approved this year and we'll be able to use it along TDM1. But there is more coming. What is coming in the adjuvant setting?
Yeah, so it's a sister study of the Compass HER2-RD. It's by the same group. It's the Compass PCR. It's called the Compass HER2-RD. RD stands for residual disease. Now, it's really important to understand that that study is different patient population than the DB05. Remember that the Destiny Breast 05 truly took a high-risk population. So it really doesn't mimic the patient population of the Catherine study that looks at TDM1. It looked at even higher risk population. Now, the Compass HER2-RD looks at the same population of the Catherine. The idea of that study is they wanted to build on the Catherine study, because the Catherine study, despite the use of TDM1, there was two big problems. The first problem is there was no improvement in the reduction of recurrences that were intracranial, so CNS metastatic reoccurrence. It really did not improve that. Remember, on the Catherine study, there was a whopping 7% chance of CNS relapse on the arm that received TDM1, even higher than the arm that received Herceptin. It was only 5% with the arm that received Herceptin. So really no improvement whatsoever in the outcomes of intracranial reoccurrence, a very important site of reoccurrence when it comes to HER2-positive disease. That's one. Two, is that although it reduced overall recurrences, patients that are not positive still, despite TDM1, at 7 years, 30% of the patient reoccurred. 1 in 3 patients had the reoccurrence despite TDM1. So that study really wanted to see if the addition of tucatinib to TDM1 can improve outcomes compared to TDM1 alone. Now, tucatinib has been proven in the metastatic setting to be active in the brain. In fact, that was one of the earliest studies and the first studies that looked at allowed patients with active brain mets, untreated brain mets, to enroll and receive tucatinib. And we've seen an impressive response rates with that agent. So this study is definitely exciting. They're bringing it to the early setting. Here, the idea is, as you're giving the 14 cycles of TDM1, to give tucatinib or give a placebo in the adjuvant setting. Now, the one thing I would say about that study, because here we like to be honest and we like to guide, our treatment physicians. Here, it's not like neratinib. Remember, with the excellent study, they did neratinib sequentially. They didn't do them concurrently with another agent. All right. When you do it sequentially, you can minimize side effects. Here, you are combining TDM1 and tucatinib together, not doing TDM1 first and then giving tucatinib. The combination, if we're going to extrapolate from the metastatic HER2-CLIMB study that looked at TDM1 tucatinib, you do see an increased signal in liver toxicity. I don't know how it's gonna fare in this early setting, because you remember, in the early setting, this is a curative setting. We don't want to be too toxic to our patient. We don't want to harm our patient, because we want to cure them in that setting. So that's one thing that I worry about. The other thing that for me it's a missed opportunity is the following. Remember that now with the DB11, we just said it, about 70% of our patients will achieve pass CR, meaning 30% of the patient will have residual disease, and in the future, 30% of the patient potentially can qualify for that study or the DB05. Now, that study truly is looking to reduce brain mass incidence by the addition of tucatinib. Yet, we do have a paper from the Sloan Kettering group showing that patients with pass CR or with residual disease have the same chance of having a brain reoccurrence, same, between 2 to 2.5%, meaning a pass CR does not protect the brain from having a CNS reoccurrence. Even more, that study showed when reoccurrence happen, if patients have pass CR, 4 out of 5 reoccurrences are intracranially, meaning the one site you need to worry about in your past CR patient for a reoccurrence is the brain, right? So we need agents that are active in the brain. It's truly a missed opportunity that tucatinib will only be given with the residual disease patients, because nowadays 70% of our patients will have past CR and will not be included in that study. Yet those patients have the same risk of CNS recurrence than the residual disease patient. What do you think, Paolo, about that?
Yeah, I think it's challenging. That paper from Emanuela Ferraro, dear friend of mine, I'll say hi to her. Ciao, Emanuela. It was like, it was tough because, we kind of expect PCR equal cure, but we know it's not true. We know that some recurrences are still observed, especially among patients that start with a high burden of disease, T3, T4, or node positive disease. And so it is tough because at the same time, to run a trial like this, you need to power it and you need to hit a certain event rate. And it's not easy to show an improvement in a trial, in a phase 3 trial, for patients that have such a low event rate like in PCR. And so I do think, let's see the data. If the data is striking, maybe somebody's going to be crazy enough to use it also with high burden of disease. And I'm looking at you. But once again, we do need to cure these patients. We have the tools. We just have to realize how to use them in the best way. And I kind of like the idea that among patients that received neoadjuvant THP, T-DXd, and have residual disease, we may have a more modern regimen with T-DM1 and tucatinib able to cure even such a tough disease that resists to T-DXd. So
yeah, and that's why I want to add one caveat here. That's why I believe that neratinib, for example, will still have a role after those studies, all those studies, especially the study over here, because the extenet, we can criticize it all we want, but they did include patients with past CR. They did include those patients, and it showed that neratinib can reduce the incidence of CNS reoccurrence.
Right. Just a reminder to everybody, neratinib is still out there, especially for patients with ER-positive disease. And remember to use loperamide if you use neratinib. A lot of diarrhea, but it is an active agent that has shown to reduce the risk of brain metastasis. And just to mention one last trial that may report in the coming year or years, Astephania. We know that immunotherapy has really struggled in HER2-positive disease. We have a negative neoadjuvant trial with atezolizumab, but there is an ongoing adjuvant trial with T-DM1 with or without atezolizumab, Astephania, and it's a large trial, almost 2,000 patients randomized, and so it's worth to look at this before throwing immunotherapy out of the window for HER2-positive disease, and we do hope to see improved outcomes. What do you think, Jason?
Paolo, I want to ask you a question here, and let's go through this mental exercise. Antibody-drug conjugates, one of their mechanism of action is they're highly immunogenic, right? They're an antibody at the end of the day. Antibody is well known to have this ADCC activity. It flags the immune system and recruits it to the area where it's active. Yet in HER2-positive disease, with all the wealth of antibodies that we have created in that cancer, we have not shown that the addition of immunotherapies are improving the outcome by just using the antibody plus minus a payload. This is very puzzling to me. Very puzzling to me. Why is that, Paolo?
It totally is. I agree. I do think we can learn from our thoracic colleagues, because the setting where they see the best activity with immunotherapy in lung cancer is for patients that do not have oncogene-driven disease, because it's like complex diseases driven by many mutations, by smoking signatures, whereas patients that have EGFR mutations, HALK alterations, etc., they don't benefit that much. And I tend to think it like this: when the disease is strongly driven by one oncogene, like HER2, you don't need so many other mutations in order to have this progression, and that's probably why immunotherapy may not be working that well. We do have exceptions. We've seen some data with neoadjuvant THP pembro that was positive, presented by Adam MacArthur, and we have seen some signals. We know that there are TILs that HER2-positive disease could potentially respond. So let's give it a hope and see if T-DM1 atezo can improve outcomes in this setting in 2026 and beyond. But
fingers crossed.
Exactly. But if there is a disease setting where we do need improvements, and we discussed about it in the in the first episode, we kind of promised that we're going to focus on this disease as a collective oncology community, and I do stand by that promise. Triple negative breast cancer, still we don't see the same outcomes of the other subtypes, but there's hope. We have seen
Mhm.
amazing data with first-line TROP2 ADCs for metastatic disease, both PD-L1 positive and PD-L1 negative. But
Mhm.
now, as it often happens, once something shows improved outcomes in the metastatic setting,
Mhm.
we take it and put it in the adjuvant and neoadjuvant setting. So,
Yeah.
Jason, tell us what's going to happen with these TROP2 ADCs in the early setting from triple negative disease.
Yeah, you're right. We did promise, and I want you to hold me to that promise. And I'm sure, Paolo, you're with me on that. We really need to improve the outcome in triple negative breast cancer, and we are. And the next few studies we're going to discuss about, they showcase this push toward improvement of outcomes. Triple negative breast cancer, especially in patients who do not achieve a complete response at the time of surgery after neoadjuvant treatment. So those patients who still have evidence of their cancer at the time of surgery tend to have poor outcomes. Those cancers tend to reoccur as short as in the first 6 months, but a lot of them reoccur in the first year after surgery. So far, we have been having very limited agents for those patients. If they have a BRCA1, 2, or PALB2 mutation, we are willing to give those patients a PARP inhibitor, which can really improve their outcomes. However, this is only 10% of the patient. The overwhelming majority of the patient, the 90%, if they have residual disease, right now we can continue the immunotherapy and add to it an agent called capecitabine. Now, capecitabine is an oral chemotherapy that I have to say here that the study that showed that it was positive is one study on a subgroup analysis. So it wasn't in the main analysis, it was a sub-analysis that showed that it improved outcome in the triple negative that came from our colleagues from Japan. Now, I have to say here, the triple negative that we see in Asia is different than the triple negative we see in the US. And that's a very important distinction because we tend to, because we call it triple negative, we tend to think all triple negative are the same. They are not. There is multiple subtypes of triple negative. The predominant subtype we see in the US are the basal triple negatives, the nastiest cancers. A lot of the triple negatives seen in Asia are the luminal triple negatives. Those are driven a lot of time by the androgen receptor and others, similar to the triple negative we see in lobular breast cancer. The triple negative we see in lobular breast cancer is not a basal triple negative. It is a luminal AR triple negative. We have a study from Europe, from Germany, the GEICAM study, that clearly showed that capecitabine is only beneficial in the luminal triple negatives, which make perfect sense. Look at what our triple negative breast cancer population. When we give them capecitabine, they don't respond. But look at the hormone positive metastatic patient. When we give them capecitabine, they tend to respond and respond for a long time. So it's really important to note. So because we did try to reproduce it at my own institution, we tried to look at capecitabine if it improved outcome in patient in the adjuvant setting. It did not. It did not. And that's why we do it, but we do it reluctantly. So we need to have agents that are active that we are using in the patient with residual disease. That's why those studies we're going to discuss right now that can be resulting hopefully this year are really important. The first one I want to discuss is with an agent that we're already using in the metastatic setting triple negative, and that's sacituzumab govitecan. And that drug is being done via an alliance with the company supporting the study, the Ascent-05 or the Optimize RD. And that study here is looking at patients who have residual disease, and the control arm is to give them the standard of care. Either you give them immunotherapy by itself, or you give them this immunotherapy plus capecitabine that we just discussed. Or you do the intervention arm where you are giving them the pembrolizumab in combination with sacituzumab govitecan in ADC that has proven to work in this subtype of breast cancer for 8 cycles. Now, the sister study to that one that I like to think about is the one using the other ADC that's coming to the market in that setting, and that's datopotamab deruxtecan, and that's Tropion Breast 03. Now, the Tropion Breast 03 here, it's a different study design. So one arm is you can give your patient the datopotamab deruxtecan, or T-DXd for short, in combination with immunotherapy. Now, in that study, they're using a different immunotherapy. They're using a drug called durvalumab. Now, it's important to note, durvalumab, pembrolizumab, we call them immunotherapies, but they're different, right? Durvalumab is what we call a PD-L1 inhibitor. PD-L1 are expressed on the cancer cells All right. Now, pembrolizumab is a PD-1 inhibitor. PD-1 are present on the immune cells. So they block different things on different cells, but both we call them immunotherapy. So that study is looking at the combination of durvalumab plus D2DXd. But there is another arm that just contain D2DXd without the immunotherapy durvalumab, and the third arm is the standard of care. So these two studies are very important, and I'm truly hope, and I truly believe, I'm optimistic that they're gonna shape the future of the adjuvant setting. What do you think, Paolo?
Yeah, I think we're actually already tempted to do this. We're not doing it. So, and with all the caveats you mentioned, we still recommend capecitabine in the adjuvant setting for patients with triple negative residual disease. But we're tempted because we know that these ADCs work so well in the metastatic setting. I do believe we should be cautious, especially in the curative setting, because there are trials that we expect them to be positive and they end up not being positive. And I always think of Pallas, the trial that I thought would be positive and it was not. But here I am very optimistic, and I think we're going to have in the future TROP2 ADCs here. There is even a third trial, an European-led trial called SASHA, very similar to ASCENT-05, adjuvant cetuximab govitecan, with an interesting difference that not only patients with residual disease and triple negative disease are enrolled, but even residual disease and ER-positive disease. And so I think that will provide some data, since we know that SG is also active in ER-positive disease and currently approved for ER-positive disease. But then there's even a set of more ambitious trials. They're thinking of replacing neoadjuvant treatment with TROP2 ADCs. And for instance, TROPION-Breast04 is one of these, is testing datopotamab deruxtecan plus durvalumab for 8 cycles compared to the traditional Keynote 522 regimen. And I think this is going to be a tough trial. It's not easy. It's such a high bar. Keynote 522, we're talking of 4 different chemotherapies plus pembrolizumab. We're talking of PCR rates beyond 60%. But the idea here is that with Dato-DXd durvalumab, you may be able to, achieve PCR in some patients. And if you do not achieve PCR, you can give adjuvant chemotherapy, additional chemotherapy. And so the primary endpoint of event-free survival here will be very important. And so once again, very tough trial. But if this trial meets the endpoint, potentially we may be able to give 2 agents with much less, hopefully, side effects compared to 4 chemotherapy plus immunotherapy, and we'll be able to use Dato-DXd durvalumab in a neoadjuvant setting. So I'm not sure when this is going to report, but I expect in 2026 probably we may see PCR data, and that may already inform somewhat what is the activity.
100%. And that's very exciting.
Exactly. We've seen some data from iSpy suggesting a high activity.
100%.
And what else? What else is coming in triple negative disease?
So you're right. So I just want to add on that. So we have the signal from the iSpy, and that's very exciting, right? They looked at durvalumab plus Dato-DXd, very well tolerated, very active. So we're very excited about that study for sure. It has the potential to really improve outcomes a lot. Now, in the early setting, before we move to the metastatic setting, there is one more study we want to discuss. There is a study, the sister of the Optimize RD, it's called the Optimize PAS-CR. So the idea of that study is that in patients who achieve PAS-CR, do we really need to give them the immunotherapy to complete the year? Right. So the idea right now is we give the immunotherapy, either you give it for every 3 weeks for 9 cycles, the 200 milligram dose, or you can go to the 400 milligram and do it every 6 weeks for 4 to 5 cycles. Now, the idea is, do we really need that for the PAS-CR patients? The answer is we don't know. And that's a study. So the optimized PAS-CR, PCR, is randomizing patients who achieve PAS-CR to either continue the adjuvant immunotherapy to complete that year, or to go on just surveillance from the beginning without giving the drug. So it's very pragmatic design. It will give us very important data whether or not we should continue the immunotherapy for patients who achieve PAS-CR. So now let's move to the metastatic stage. The beauty about having you, Paolo, on this podcast is, I'm going to say it today on this podcast, you are the king of ADCs. Point blank. You are the shining hero of antibody drug conjugates. That's why I'm so glad that I do this podcast with you. So please take us through what is the next promise for our patient with triple negative breast cancer when it comes to ADCs with the tropium-breast-05.
Yeah, we just saw the shiny data, and I don't know well other way to say it, of tropium breast 02. We saw that Dato-DXd in the first line setting for patients ineligible for immunotherapy but with metastatic triple negative disease achieved a median PFS exceeding 10 months, an improvement in overall survival, a response rate of 60%. I think those data were striking, and we do expect to have Dato-DXd available, hopefully approved this year for treating in the first line patients with triple negative disease not eligible for immunotherapy. But what about the other ones? We don't like to leave anybody behind, and there is a trial, Tropium Breast 05, testing Dato-DXd with or without durvalumab compared to chemotherapy and pembrolizumab in the first line setting for patients with PD-L1 positive triple negative breast cancer. And this population is a population for which usually we see better outcomes, fortunately. And this is why I'm excited, because if we saw over 10 months PFS in PD-L1 negative, in IO ineligible, what are we going to see in PD-L1 positive? And of course, we don't know if this is going to report this year, but I think it's going to report soon, because unfortunately, we do see events in this population. And once we see that, I think the puzzle is going to be somewhat complete, because we're going to have both TROP2 ADCs available in the first line for both patients with PD-L1 positive and PD-L1 negative disease. And then the major question in the field will become, and it already is, what to give afterwards, because this ADC sequencing question is big. And so what, I think we're preparing for the third episode already, and we're thinking of having some amazing invited guests, secret invited guests. So I'm throwing it out there, get ready, because the third episode will be in person in a wonderful place with an amazing invited guest. And I'm preparing to ask that guest a lot of hard questions. One of it is how to sequence ADCs, but there are so many additional tough questions. And we are here to answer the tough questions.
That's exactly why we're doing this.
Exactly. So I'm super excited, Jason, super happy of having started this podcast. Second episode, we're getting ready for many more. Let's do this.
Let's do this. Thank you all for joining us. Don't forget to follow us on your favorite platform. We're on every single platform, either by video, audio, or by audio only.
Spotify,
Don't forget
Apple
to prescribe
Podcast.
and follow.
Exactly. Ciao.
Ciao.